Welcome back to this section on lung ultrasound. In this section, we will more specifically look at how to diagnose pneumothoraces, the interstitial syndrome, pleural effusions, and lung consolidations.
I guess what you're trying to say is that if we resuscitate patients for a living, this is something we gotta know.
Exactly it. Lung ultrasound can be approached with just about any probe. Linear transducers have a higher frequency that allows us to see the pleurals better, but they can't be used for most other lung stuff.
Because they don't see deep enough, right?
Exactly.
But low frequency probes see deep enough, so they're the ones we'll be using for just about anything lung related. Although we can see lung sliding with them, it can be a little bit harder because they lack definition in comparison of the linear probes. Where will you put the probe depend on what you're looking for. Obviously, in a supine patient's fluid will accumulate first in the posterior region, while air will go in the patient's most anterior aspect.
So let's start with pneumothorax. If you have subcutaneous emphysema in a patient with a super tight chest, then you should probably strongly consider proceeding with chest tube right away and not use the ultrasound. Otherwise, this is an awesome tool.
So the patient comes in feet first, and this is his pneumothorax. So to look for a pneumothorax, we just want to assess the anterior portion of the chest.
So we put the probe around the fifth intercostal space, maybe a little bit higher, around the mid-clavicular line, with the marker pointing towards the patient's head. That's always our default position when we're doing these longitudinal scans. In a crashing patient, a one-point assessment might be enough. Make sure you assess the area that seems to be the most anterior on the patient's chest.
If we're looking for subtle ones in stable patients, we'll want to cover 4 main regions on each side. So one around the second intercostal space and another one around the fifth intercostal space. And we'll look at the medial and lateral part of each of these regions.
And that will give us a total of 8 interrogation points. Of course, there are many types of chest, so look at the patient and actively ask yourself, where would air go? That sure can't hurt. So this is the image we're aiming for. Marker here is pointing towards the patient's head, so screen left is cephalad and right is the patient's feet. Here,
we have our landmarks that are the ribs with their shadowing and our area of interest, which will be the pleural line, and it's normally around 0.5 centimeter behind the anterior aspect of the ribs. So the pleura are 2 thin sheets sliding one over the other, but don't expect to see a big motion here. What we see is kind of a shimmering at the pleural line.
or ants walking on the line or something like this. So we have another example right there. Find the ribs. Make sure you look roughly 0.5 centimeter behind the ribs. You find the pleura, bright echogenic.
So ribs first.
Always.
If we have a crashing asthmatic patient, someone on a vent, or who's been in a car wreck, really this is the fastest, most accurate thing you can do at bedside to rule out a pneumothorax. Seeing lung sliding guarantees you 100% that this patient doesn't have a pneumothorax under the area you're probing.
And again, another example right here. If we look on the top left corner, we notice how you actually see the rib, then you see the pleura, and then there's a shadow, whereas on the bottom right, there's nothing behind the rib. There's a pure shadow behind that rib. Why could that be?
Well, near the sternum, ribs are composed of cartilage, which is dense but less than bone. So we still see our bright echogenic pleural line and then nothing more.
And that's also why it's so easy to do thoracic ultrasound in children. Again, right there, so you see the pleura behind the ribs. There's that small shimmering, ants walking on the line.
Yeah, and there doesn't have to be a lot of movement for us to be able to see it when we know where to look for. What to look for, I'm sorry. Here's another example here that's done with a phased array probe. If you have difficulty assessing for lung sliding, to make your life easier, you should decrease the gain. Because lung sliding is kind of a shimmering, and it is going to be more difficult to see if you oversaturate the screen with too much gain.
Here, do we actually see sliding? Yeah, we see it, but it might be kind of subtle, but it's definitely there. If you're not sure, look at this clip on the right here. Do you see lung sliding right there?
Now, on the right, there's absolutely no lung sliding. We can see the difference with the 2 clips side by side. So this is the same clip. So there's sort of a movement at the beginning. So maybe the patient or the operator moved. But if we're systematic and we find the pleura, we clearly see that there's no shimmering there. So there's no lung sliding here. And it's really this distinction that allows us to use lung ultrasound to detect a pneumothorax.
Let's look at another example of abolished lung sliding. This clip was done with a phased array probe. So the ribs are somewhat difficult to identify, but there they are. Behind that, there's a pleura, and there's no sliding at the level of the pleura. If we're not convinced, one thing we can actually do is to use M mode. So we place a cursor on the pleura, just make sure it's not too close to the ribs on each side, because when the patient breathes, it will block the signal. When we press M mode again, we see this. All the structures above the pleura don't have any vertical movement, so they look like horizontal lines on M mode. Below the pleura, the lung inflates, deflates, it's chaotic, there's all these artifacts, so it's a granular pattern, and it kind of looks like a beach.
This is called the seashore sign. And man, I live in Montreal, and in the winter, this is a sign I like. M mode is really useful for less experienced clinicians or difficult patients because there's a sharp contrast between normal lung sliding and abolished lung sliding.
Indeed, the pneumothorax looks like a barcode. You only see these horizontal lines, so it's very different from what we normally see from the normal seashore.
So pretty much, this is just another way to illustrate the same phenomenon.
Exactly. M mode can help us to document with a still image the presence or absence of lung sliding should you need to do this, but its real utility lies in the fact that it can help us be more convinced of our own interpretations. So basically, we don't need to do M mode if we're already convinced with our 2D assessment.
So whenever we see lung sliding, we can be certain that there's no pneumothorax under the area we're assessing, obviously. But when lung sliding is abolished, there's a differential diagnosis we have to make. It can be a pneumothorax, but it could also be because the pleura are glued together, like in a pleurodesis, or when you have ARDS or a pneumonia that will generate an inflammatory reaction that will tend to bind the pleura together. Now, what if there's no alveolar ventilation?
Like in a main stem intubation, for instance, or a severe bronchospasm, well, it might kind of be hard to see lung sliding. But in every instance, except the pneumothorax, we should see this other sign. Here we actually see the lung is not really sliding, it's a pulse, it's cyclical. So what we see are the heartbeats transmitted through the lung up to the chest wall. But let's say the patient had a pneumothorax. Will we be able to see this?
No, because air between the pleural layers would disperse the beam, and we wouldn't be able to see further in. So seeing a lung pulse, just like seeing lung sliding, rules out a pneumothorax, and it's a very subtle movement that can be easily hidden by lung sliding. So it generally also implies that there is no or low alveolar ventilation.
What happens when both lung sliding and lung pulse are absent? Does it mean that the patient has a pneumothorax? Well, most likely yes. But sometimes lung sliding and lung pulse might be subtle, and to be 100% positive, you need to seek for this other sign, the lung point. To understand the lung point, let's look at this pneumothorax right here.
Okay, so what would you see if you put the probe here?
Well, there's no lung, so I guess I wouldn't see any lung sliding in that area.
Great, but what about if we put the probe there?
Over normal lung, well, I should see normal lung sliding, I guess.
Great. Now, if we put the probe at the exact location where both pleuras separate, what will we see?
Well, when the patient breathes in, the lung will inflate. It will thus come in the ultrasound field of view. And as the patient exhales, it will tend to go out of the ultrasound field of view. So you'll see it coming in, going out, coming in, going out, comes in, goes out. And notice how all during that clip on the left side of the image, the video, we do not see any lung sliding at all.
So this is the lung point, and this is pathognomonic for a pneumothorax. So every time the patient is stable, you should take time to find this.
So essentially, I look at my patient, those 4 points, upper chest, lower chest, medial and lateral, and if in one spot I see lung sliding, in the other I don't, well, I will try to find the area in between those two zones where you actually see the lung point, where you see the pleura separate. If you don't see any lung sliding on all of the anterior chest, you might want to look on the patient's lateral chest. Now, is this a good tool to quantify the size of a pneumothorax?
Well, not precisely, but the smaller the area of abolished lung sliding, the smaller the pneumothorax. But as a rule of thumb, the more lateral you need to go to find the lung point, the bigger you can expect the pneumothorax to be. Now, one important thing, if you're thinking about a tension pneumothorax in an unstable patient, obviously you won't lose 2 minutes to try and find that lung point. Just the absence of lung sliding, lung pulse should make you very concerned that there's a tension pneumothorax there.
Otherwise, those 2 minutes will be very helpful for the other side's lawyers. Let's look at other examples, Jean-François, maybe.
Okay, so here's an example of lung point. So you see on the left side of the screen, lung comes in, or lung sliding comes in and then out as the patient exhales.
Here, the same thing. It comes in, goes out, comes in, goes out. And it's always a bit easier when you do it yourself because you know where you should see lung sliding, where you shouldn't. Now, notice this line right here. It slides. Those are not the pleura.
No, so find your landmarks. Identify the ribs and half a centimeter below. This is what you're looking for.
And that was a really thin patient. So imagine a bigger patient. It would be lower in the screen. It would be even easier to mess it up. Now, what do we see here? Is that a lung point?
No, because there's some structure there. This is the heart. And that would be the worst place we could stick a drain in.
Definitely. Anyways, it's a bad question because all through that clip, we actually see lung sliding, and lung sliding rules out the pneumothorax. And we'll look for a lung point when we don't see lung sliding or lung pulse in a given zone of the patient's chest.
Now, if there was air, you would not be able to see deeper structures and would not see the heart or lung sliding for that matter. So if we are lower than the fifth intercostal space, we could also bump into the liver or spleen, and that would kind of produce an image that is similar. Lung ultrasound has a sensitivity and specificity that approaches that of a CT scan. And we've found many quite big pneumothoraces, up to 40%, that were really difficult to see with supine chest x-ray, even if we look retrospectively. But it's easy to understand why when we look at the CT scan.
If we actually look here, there's lung parenchyma from left to right. So imagine that AP chest x-ray. It would not be hard, it would not be easy to see that pleural separation. You would need a much bigger pneumothorax for you to see that. And that's why it's a lot more sensitive to look at it with ultrasound.
So getting back to whether or not our patient has a pneumothorax, well, he doesn't if we see either lung sliding or a lung pulse.
And as we'll see in the next section on interstitial syndrome, B lines being generated by the interstitium also rule out pneumothorax.